Hi, I'm Kriti Ahuja. I'm a third-year hematology and medical oncology fellow at Roswell Park Comprehensive Cancer Center.
I'm Dina Ioffe. I'm a GI medical oncologist at Fox Chase Cancer Center.
So with the combination of PARP inhibitors and immunotherapy, including drivalumab, which has been presented in ASCOGI, and we're looking at it across the GI malignancies, what's the biological and clinical perspective? What's the rationale behind it? And what are some of the early signals that we should look out for to know if this has actually got real potential?
It's a great question. So the PARP inhibitors work by inhibiting DNA repair, double-stranded DNA repair. So in patients who have a BRCA mutation, they're unable to bypass that. So if somebody who has a BRCA gene intact, they can bypass that PARP inhibition and repair DNA strands. So in patients who are BRCA mutated or who have HRD, they basically have an accumulation of mutations. And between that and developing some more neoantigens and also upregulating PD-L1 in the tumors, you basically are creating a hot tumor microenvironment that is theoretically going to be more responsive to immunotherapy. This is a combination that's used in other disease sites. It hasn't so far panned out as well in GI tumors, and we do have preliminary data that was presented today with the normal caveat that you shouldn't do cross-trial comparison. It seems like the numbers are pretty similar to the POLO trial. So the question is, how much benefit do you get while also exposing somebody to the potential toxicities of immunotherapy? So I think it's too soon to say. The best thing, obviously, is improved overall survival. So I think if we see that, like a significant benefit over PARP inhibition alone, I think that would support really incorporating that into our practice.
Yeah, thank you. And so what are you most excited about at ASCOGI?
There's a lot. I think everybody's talking, there's a lot of buzz around the KRAS inhibitors in pancreatic cancer, and it seems like that's going to really change practice. We've been using the same chemotherapy combinations for a very long time, and so it's exciting to have new potential targets in a very aggressive disease with a historically poor prognosis.
That's true.
And where there haven't been a lot of targeted therapies. And similarly in biliary tract cancer, which also has a poor prognosis, I think that's, the field of targeted therapy is really evolving, which is exciting to have all of these potential options for our patients.
And in terms of how this actually plays out in clinical practice, in community oncology, which is where a lot of our patients are seen, what are some of the key takeaways that community oncology physicians should take away from this conference? And also realistically, how is this going to affect practice, and how is that going, and what should they keep in mind? What are some possible challenges, diagnostic testing wise, as well as treatment wise, that they should kind of consider?
Yeah, I don't think there's anything practice changing yet. There's a lot of promising data that we need, either more mature data or phase 3 data. So the biggest takeaway is, I think, always do molecular testing, rebiopsy when you can.
Yeah.
I think the challenge is, if you have an unresectable pancreatic cancer, it's hard to get good tissue. And liquid biopsies aren't always successful or aren't always fruitful.
That's true.
So, but yeah, retesting and checking always for new molecular mutations and considering clinical trials, I think, is the biggest thing. And also seeing what's new, what updates there are, because now there's a lot that's changing rapidly, which hasn't always been the case.
Thank you so much.
Yeah.